Can I close it? You're having some tech issues, just give me a second. So before starting, let me walk you through some basic, knowledge what we have, that, there are some common forms of coronavirus. This is not something unique. This is a new mutant form of a coronavirus that we call as 2019 nCoV. So it is not same, and that's why the diagnosis of this coronavirus is very different from as compared to the other coronaviruses what we had in the past. There is a coordinated effort from CDC in US. What they're basically using is a PCR-based technique, and I will come back to that. In relation to the exact source, there is a lot of effort. We hear a lot in the newspapers regarding how the infection originated, but it's still not confirmed. So people are still working on it, and this is coming out of peer-reviewed publications, what we see in the recent data. We definitely know that the potential source was animal, and now it is highly contagious and it's spreading from human to human. And the symptoms are certainly, primary symptoms are respiratory. So you start with a fever, other than few exceptions, and you have cough and dyspnea. Dyspnea is a shortness of breath. It's stuck. I see. So as we all know, it started from the Wuhan province. This graphical image just got published in Lancet. You'll see on the left side, the scale is in thousands of subjects. Of course, a lot more patients in the Wuhan province. And the green line shows you the scale on the right side, which is in hundreds. And those are outside the mainland of China. And on the bottom of the screen, you see how it is transporting or sort of spreading across different continents now. Luckily, we have made actually sort of very quick progress in sort of identifying not only the features of this virus and also come up with strategies to handle it. We already know the full genome sequence, which came out from Pasteur Institute, and this got just published on January 31st. What we know from the sequences, there are at least 8 complete genomes, which are almost 99.98% similar to this coronavirus. So what this tells us in the basic terms is that there is only a mutation, and that's why there's the emergence of this new virus. And these mutations, what we know, the largest mutation, what we have seen in this sequence is only four mutations in the entire sequence. And you can find the entire publication. The reference is right there. Pathologically, we now have some data, imaging data, and I will be showing you some new technique what we are developing. So these are images from X-rays from the patients on the first day and the second day of the infection, as well as the CT scans. And what we know so far as a part of this study, which again got published in Lancet, that 74 or 75% of the patients have bilateral pneumonia, meaning pneumonia on both sides, and 25% have unilateral pneumonia. So one of the typical feature what you'll see in all of these patients is pneumonia, and I will get back to what that really mean in sort of basic terms. 14% of the patients on the CT scan are showing multiple mottling, which is more of a term for radiologists, showing sort of a ground glass opacity. Again, typical features what we see in pneumonia. There will be only like 1% patients which have pneumothorax. So pneumonia or some sort of ground glass opacity or pneumothorax are the features on the imaging data sets. In relation to phylogenetic analysis, what you see in this figure is right on the top, that this aligns very close on the phylogenetic tree with the SARS coronavirus, which is suddenly had much more lethal consequences. I will not say the virus is less lethal. Only difference is that we are far more prepared this time around to handle it. We have already identified the complete structure as you can see in the bottom panel in the C. We already know the ligand receptors for most of the other parent viruses like SARS or the MERS viruses, which are also the coronavirus family. But of course, we have not yet identified. We know the moiety for this novel coronavirus. So far, what we have seen in these recent studies is that this coronavirus has a typical feature which causes a very severe form of pneumonia. We have identified the origin and the receptor binding properties. More generally, the virus is hidden in more sort of wild animals, and their potential is occasionally spilling over to the human, and that's where it's now spreading from human to human. These are the electron micrographs of the viruses. On the left side, what you see is a negative stain of the virus, and on the right side, when inside the airway, the virus infects the epithelial cells, you are seeing those virus particles inside the epithelial cells marked by the arrows. So made quite a bit of progress, already know quite a bit about what's the exact sequence of the virus, how does it look like, what are the pathological features. So that's a significant progress. Structurally, it's not very different from the rest of the other coronaviruses. I know a lot of people wonder who are not from the field why it's called coronavirus. Coronavirus is a very common form of viruses, and I will talk more about it. Corona means a crown in Latin, and if you see there are spikes or crowns on the surface, which are basically glycoproteins on the surface of these viruses. So that's why it is called coronavirus. We also know the M protease complete structure, a ribbon diagram, which now allows us to design the antiviral drugs by modeling against this coronavirus. And this has all happened in matter of few months. Respiratory infection is suddenly the onset, so I want to make sure that everybody is very clearly aware what are the things what are pointed out by CDC. Of course, most of us know that it's spreading through the air, can be through cough and sneeze, through a close personal contact by touching or shaking hands, and on the surface of the objects when you capture it, and if you have not washed your hand and then you go ahead and touch your mouth, nose, or eyes, those are the sources of spreading the infection. To clarify, it's really get spread through the fecal contamination, so that's not an issue. So it's spreading is again through the coming through the coughing, sneezing, airway route, or getting it through the surface. This is the map, and if you see on the left-hand side the number of cases, they were updated on February 23rd. There were 17,000 infected cases, 362. But as of yesterday, it's now 20,000 plus and 400 plus, and this is rising as the clock is ticking right now. Of course, we see in the bottom panel, it's in Asia Pacific region, spread also to Australia, Russia, more so in Canada, very few cases in US. I think it's like an 11th case right now in US. Typical features, as I told you, fever, cough, sore throat, and difficulty breathing. But as an advisory, what we know for sure is to avoid the contact with a sick person, avoid going to the animal markets, avoid contact with a live or a dead animal, including uncooked meat, is always a good idea. Wash with your hands at least 20 seconds, not less. And if you feel sick, you have a fever, cough, or difficulty breathing, immediately go to the doctor. Do not travel while sick because you may propagate virus to others. So it's not only for your safety, but also caring about others. And cover your mouth and nose with a tissue when you. This is basic things what we teach in the school to the kids while you cough or sneeze. Again, starting from the airway, although initially what you see is fever, fatigue, dry cough, shortness of breath, but it gets fairly quickly into your circulatory system, and that's where we can pathologically identify too when a patient has a decreased number of white blood cells, So we can do a blood test and identify that too, and it also leads to decreased function in the kidneys. So directly addressing the need of this group for the entrepreneurs and those are into the biomedical innovation, how you can get involved to help the field here. There are lots and lots of opportunities, and I put them all for you guys. On the diagnostic side, FDA is clearly saying there is no FDA approved diagnostic as of now for 2019 coronavirus. What we are using right now is a PCR-based assay, which is CDC is doing. These are not FDA approved diagnostics. So there is a request out there from FDA. If you want to do that, you can contact FDA. There is an email address, and I will give these slides with the contact information to Frank, and he can circulate to the group. That way everybody can have it. You can go and contact FDA to submit and figure it out how you can submit your pre-application, and from there, if you are invited, you can submit the full application. Same is the issue with the vaccines. There are no approved vaccines for the coronavirus, or actually any other form of coronavirus is what we know from long time. So we really don't have a vaccine for coronaviruses. So you can again have an email address there to contact the FDA, and there is a phone number as well to see where there is an opportunity for you to submit a grant or get a funding to submit that. For the therapeutics, no drug out there. FDA is asking for a pre-IND consultation program, and this information can be found if there is any ongoing trials on the clinicaltrials.gov. But other than trials on looking into spreading of coronaviruses, they are not really the therapeutic trials, other than one trial which came out of a Wuhan Institute of Virology, which is affiliated with China Academy of Sciences, and they have actually applied for a patent on a Gilead Sciences drug called remdesivir. And this is a very, very good news, because company is partnered with Chinese health authorities to run a phase 3 clinical trial and see how fast things are moving. So I'm fairly optimistic. And the advantage is they are, of course, trying to test the further efficacy of this drug on people who are infected with this virus. But what we know is drug was initially developed for Ebola virus. It didn't actually work. It was ineffective for Ebola viruses, but then they repurposed the drug for treating this new form of or a novel coronavirus. And it is really neat to see how you can use the libraries of ongoing compounds and therapeutics and repurpose them for other purposes. So this allows us to screen for drugs. And this came out of a preclinical study which was published in New England Journal of Medicine, and where it has shown a significant effectiveness against this novel coronavirus. In addition, we also had one case in US with a patient. Not many people know about it, so I'm giving you offhand information. And this patient was treated with this drug to compensate the disease on day 7, and the condition of the subject improved on day 8. So that's promising, and looks like they will go for the phase 3 very, very quickly. So we should hear about what's going on with this drug also very soon. But still, there is a lot of opportunities. As I'm telling you, there are protein structures identified, all those kind of things, those who work on the modeling and things like that. Frank has a question here. Not as of now. This one, it will get started, I believe, at Wuhan Institute of Virology. I believe there will be other institutes all over the China. I'm sure US will start these trials, and that's where FDA is looking for these therapeutic trials as well. And that's where you have that pre-IND consultation. The problem with the FDA is the process is very, very long to get anything approved. So for those who are in China, I will strongly recommend to work with the Chinese Health Academy to work through those sources. Of course, when we want to get those drugs into US, we need to get them FDA approved. And I'm happy to consult or team up with anybody on these kind of projects. I have all the expertise on these kind of things. I'm sure there will be trials getting started here in US, but it's a lengthy process in US. And for the product developers here in US, you can apply from outside as well. You can also contact this agency called BARDA, which is Biomedical Advanced Research and Development Authority, which is a part of Human Health Services Assistant Secretary Preparedness and Response Program, which is triggered in these kind of epidemic and emergency. You can submit your ideas online through the portal, and happy to share the link. You can find my email address from Frank, which he will share after the talk. We already talked about what is going on with the initiation of the disease. I just wanted to point out on this slide that if you see, coronaviruses are typically infections of the upper respiratory tract. Although what the symptoms we are seeing with this virus is mainly pneumonia, which is a symptom of a lower respiratory tract. And diseases which infect the lower respiratory tract are a lot more severe. So my understanding is the disease gets initiated from the upper respiratory tract, but it's very quickly get converted into a pneumonia infecting the lower airway, which is anticipated. We already have, based on the disease location, a protocol. I don't know whether this is the same protocol, but more or less this is implemented across the globe, that whether the disease is for upper respiratory tract or lower respiratory tract, what they right now do is, if you have the high risk factors for upper respiratory tract infection, you just put the patient, if these features are absent, you put them on a supportive care, but if these risk factors are present for upper respiratory infection, you're putting on an antiviral drug, which is called ribavirin. For the high risk features drug for the lower respiratory, which is more severe of a disease, even if it is absent, you're directly putting the patient on the drug. And if the high risk features are present, you give the aerosolized form of the drug, which is far more potent. So you give not the standard drug, you give aerosolized form of a drug, which is far more effective for the airway infections. And we know quite a bit about the viral infections from a whole lot of other diseases. So I'm using an example of a chronic disease called cystic fibrosis here to show you respiratory viruses not only modulate your immune response, but they can change your metabolic outputs, not only for the bacteria, but also for the host. And this will lead to acquisition of new bacteria. The community composition of the various bacteria and viruses will change in your airway. And overall, the bacterial burden changes. So it becomes far more complex than just treating one virus. We know quite a bit based on the group under which the coronavirus falls. It falls under a syndrome called CORSA, which basically in simple terms mean that inflammation or sort of more thickening of the mucous lining and everything on the upper respiratory tract, but clearly it spreads, leading into the inflammatory phenotype in pneumonia in the lower respiratory tract. You also see in this list all sorts of different viruses from RSV, which causes bronchiolitis, or the influenza viruses. So this is not something new what we are dealing with, on the respiratory infection side, pretty used to dealing with all sorts of different infections. So before I put things into perspective as compared to other viruses, just sort of a general outline how the disease looks like as compared to the normal subject. So if you see the lumen of the trachea of a normal subject, what you see is there is a muscle around it. There's a smooth muscle, and you see the lumen is quite large, and there's no thickening of the lining of the lumen around the lumen. But as soon as the subject gets infected, you will have a thick, smooth muscle cells, a very narrow lumen, and this is happening because of inflammation. There's thickening of the mucus, and there is a lot of mucus buildup as well. So in addition to this increased mucus secretion, which quite a bit I have worked on, working on chronic obstructive lung diseases such as COPD and cystic fibrosis. In this case, we also see a lot of white blood cells. So in patients, what you are doing is, and I have seen already studies coming out in Lancet and New England of Journal, medicine, it's a very standard approach. You take the bronchial lavage from the airway, and in that you'll find the counts of WBC changing. Also, you can collect the virus, and right now we even know the sequence. So we can really very clearly identify by the PCR technique that it's in fact the coronavirus. To put things into perspective for you guys as compared to other forms of infection, and I'm using an example of influenza infections here in US. And if we look into even a seasonal influenza virus, what people don't realize is that there are almost 140 to 710,000 hospitalizations we get every year here in US from just from the influenza epidemic every single year. And I'm sure it's a lot more in China. And there are almost 12,000 to 46,000 deaths from the influenza. We don't hear about it, and we think, if you think 500 is a large number, I'm just putting things into the perspective. Not that the difference is we know how to treat influenza, we don't know how to treat novel coronavirus. We are making certainly progress on that aspect. And in addition, like I'm using an example of influenza virus, which is very much applicable to the novel coronavirus as well. They are comorbidities, which means is that if you have any of these conditions like asthma, chronic lung disease, heart disease, endocrine disorders, or even liver disorders, extreme obesity, you are at risk, or you are at a greater risk to have complications from influenza or even from coronaviruses. So the reason people die, some people die and other people don't die because they're suffering from one or the other comorbidity. And a lot of times you don't know what you have. And CDC is very clear, and I really like this flow chart, and this can be very, very handy. So there is a very good sort of a flow diagram kind of a thing for clinician or anybody working on the epidemiology side, how to deal with this epidemic. Basically how they're identifying is, since the origin of the virus is from China, anybody who has traveled from China or have got in close contact from somebody from China. So those are and if those folks have, in addition to that, symptoms like fever, I told you, respiratory illness like dry cough or shortness of breath, you have to isolate those patients. And in US, when they are arriving, they are giving them opportunity, volunteer basis, to allow you to quarantine. So you go through a two-week quarantine where they let you go home eventually. So which is a very good thing to do for everybody. Simple things: place the face mask on the patient, isolate patient to a private room, and use PPE, which is personal protective equipment, very standard for any kinds of exam. And what they're looking for is the symptoms, which I already told you: cough, shortness of breath, fever, and then they are informing the patient about what is their clinical status. They take the specimens. In US, they send specimen to CDC right now, but CDC has actually published the PCR sequences and the protocol. So anybody can take that protocol from the CDC website and actually use, not by yourself, if you have a facility where you can do virology, to actually identify if this is a coronavirus in a particular sample. And then eventually, the clinician or the person who is treating this gets to decide. Most of the time patients get discharged if there are no severe symptoms like pneumonia and other things. And then patients are instructed to take care of themselves at the home, whether stay in the isolation or, what other things need to be done. And clinically, it's a very standard procedure, going through the imaging, physical examination, blood tests. Some of them I already alluded to. Chest X-rays and CTs, I showed you some examples. Pulse oximetry and sputum test. So either you take a lavage or a sputum sample and actually look for the virus. You can either do a PCR, or there are a lot of other standard diagnostics we use for viruses. PCR is the one we are using right now. Eventually, I'm sure we'll have antibodies and we'll work on detection of antigen. This also allows you to isolate the virus from the swabs. In this case, you do it from the lavage. And serology is another infection, another diagnostic, but airway infection is a lot of time diagnosed by imaging, because that allows us to really look into where exactly the infection is, what is the state of the patient, how the disease is progressing, and when you are treating the patient, are you able to control the disease. And when you're especially developing a new therapeutic, it allows you to see in the real time if your therapeutic is actually working. And that's where I will show you some of the new tech, what we have been working. I'm working with 4DX to take them through the FDA approval process right now on this technology, running several clinical trials on this technology. We have 2 IRBs approved at Hopkins for COPD and cystic fibrosis, and another one at Duke for lung transplant. Just completed a study on radiation therapy at Cedars-Sinai. This is all the work from 4DX and the team from 4DX. I run their clinical development. And what these folks are able to do in this study, or what they have developed as the technique, is a technique which can sort of go through shortcomings of all the diagnostics what we have, not only in US, actually globally. So the standard techniques what we use for respiratory diagnostics is spirometry, which is called pulmonary function test, or a chest X-ray, or a CT scan. So spirometry is a technique which was developed in 1816s. It's still very, very handy because you make a patient blow the air, and you basically record changes in the pulmonary function or ventilation from that. It's accurate, but it's insensitive, and the reason for that is if you have, suppose, a disease in one corner or one part of the lung, what pulmonary function test gives you is a sort of a global picture. So total amount of air you have pulled out from both the lungs. And human system is very, very smart. So if you have a small disease initiating somewhere, if we take an example of coronavirus getting initiated, early stage you don't have symptoms. When we are catching up these patients are when the symptoms are blown up. So when you catch the disease late, what happens is your ability to save the subject is very, very difficult. So it reduces on our ability to identify that early. Suddenly, bigger changes you will record by this technique. Chest X-ray, very, very classical. We find in every niche and corner in all sorts of clinical practices, very inexpensive. But it does not give us a whole lot of information. And you saw on those pictures what I showed you earlier of X-ray versus CD. So you don't get too much information other than you are looking for broken bones or things like that, but in the respiratory sense. So again, it's also a one-dimensional. CD developed in 1970, 3-dimensional, useful, sensitive, expensive, high dose of X-ray, and that's the issue with the series. So what 4DX have done is that basically combined all the benefits of all these technologies, and what they try to do is they are measuring changes in motion from where they can calculate the airflow inside the airway. They're also working on a technique to develop the blood flow, so ability to measure both ventilation and perfusion. And since this is all 3-dimensional, done over the course of the course of one breath, so it's basically a 4D technique telling you exactly what's happening in the subject's airway. So what they are able to do, or what we are able to do here, is combine the functional insights of spirometry, provide you regional measures with a low dose of radiation X-ray and high detailed resolution of CT scans. So benefit of each of these techniques, very low dose of X-ray exposure. So quite powerful. And how it is done clinically, idea of introducing you guys, since you are innovation and entrepreneur group, is to introduce you to a new tech that should sort of stimulate new ideas on your side to see if you can come up with something better, or come up with another idea on aspects what you're working on, whether with the diagnostics, whether with therapeutics, all sorts of different things. But it's very interesting to always look into how different technologies are developed. So in this case, what we ended up doing was we are using, in our current clinical trials, we are using the existing fluoroscopes in the hospital. And the advantage of that is the technology can be rolled out very, very fast. And what we do here is we actually use this existing fluoroscope to actually take series of images. Somehow the animation is not working right now. To take series of images across the I don't know why the animation is. So to take the series of images across the patients from 3 to 5 angles, now it's working. So instead of taking hundreds of slices of X-rays, what we do in the CT scan, we are taking only 3 to 5. And this reduces the amount of X-ray exposure on the subject dramatically. So right now, although they're using the current X-ray fluoroscope, the technique came out of Monash University in Australia. Original inventor Andreas Foras was a faculty at Monash, and eventually the goal is to actually develop a dedicated scanner for 4DX, which will be something like this, similar to what kind of X-rays you go in the airport. The patient can be in and out kind of a procedure, so patient don't need to lie down or anything like in a CT scanner. You just go stand up, and they literally take your X-ray around you using a screen X-ray, and it can be quick. Even right now with the fluoroscope, our procedure is like a 30-second procedure. Since a lot of you are on the tech, maybe on the biomedical engineering side or engineering side, so the idea about showing you the concept behind the technology comes from the wind tunnel image processing. So you can apply the knowledge from the engineering side or totally different field to really serve something unique need on the healthcare side. And that's where, as an innovator or as an inventor or entrepreneur, you need to really stimulate your ideas to see, first of all, where is the need. So it's very important to look for, really where is the need, and then see how you can come up with a new novel idea to apply. And a lot of times when you're thinking, coming from the engineering side, you have unique ideas. So you're trying to come up with approaches. So here what they are doing is basically using the old conventional ways of measuring the flow of air inside the tunnels to come up with algorithm to using a standard camera and a laser to measure the changes in the motion in the airway. From where using this algorithm by voxel, you can actually calculate the changes in the airflow. So as I told you, using the fluoroscope, what we try to do is measure or reconstruct the 3D motion field using these 3 to 5 projections. And what this allows to do is on the airway tree, using the pre-existing CD from the patient, you never need to repeat any CD on the patient. You simply use these fluoroscopes. So you can really map these regional changes voxel by voxel on the subject. And these little arrows, what you're seeing in the green, red, and the blue color is the direction and the flow of the air inside the lungs. So you can literally tell where the air is flowing in or where the air is flowing out the airway. So as compared to the technique I was telling you earlier, spirometry, where you're just blowing out the air and get a total number, this is a lot more powerful because you can go exactly in the lung where the, suppose a pneumonia is, a tumor is, infection is, obstruction is, and you can tell region by region. So a lot more powerful because you can detect quite early as the disease starts. You don't need to wait till the whole lung starts responding to it. So in relation to output, what this technique gives you is a ventilation scan. So how air is filling in or going out of the airway. On the airway tree, when we map it, you can literally see on each and every component of the airway where exactly air is flowing in or flowing out. Quite powerful. Beauty of the technique is that you can go region by region and see in which arm of the airway tree you have infection, obstruction, anything going on, and you can actually compare this over time. So track one region and track it over time, over different periods of time. A lot more powerful than any other imaging technique out there. And this is what you get as an output. So you get these ventilation maps, you get these airway trees, and if you're seeing a change in ventilation, you can technically correlate it. In this case, there is obstruction in this subject, in this branch of the airway tree. To simplify, what we are doing is taking sequences of X-ray images, lot less than what you take in CD. From there, calculate using the algorithm, the 4DX tissue displacement, which is a motion, and convert that to the direction and the intensity of the airway flow, and which is shown as a ventilation map, and it's region by region. That's a difference from any of the current techniques. So in this figure, you can actually see that when you can go inside the lung region by region, it becomes very powerful. It's very easy when you have no disease, but when you have, suppose, a small defect in right middle lobe, which is a mild form of disease, you will almost certainly miss in any of the current techniques, but you will be able to catch it here. Likewise, this subject has a defect in lower left lobe, which is more of a moderate case. Again, you may catch slight change in PFT, not really at all. Severe stages you may catch on PFT, but this tells you exactly the infection or problem here is on the right lung, not on the left lung. So you know exactly where the disease is. So power of both giving you the actual quantitative numbers as well as the image. So that makes it a lot easier for the clinicians. In this image, what you see on the left side is again the ventilation map, and what we do here is we are using that airflow data and the ventilation field data to come up with the association of ventilation field data with the using the airway tree structure, which we can take from any past CD on the subject, and we come up with this airway flow structure, what you see on the end. And you can have that in a movie form or all sorts of different forms. So I can just, before winding up, show you a couple of cases from a radiation therapy trial, which will be published soon. And the idea of using this radiation therapy is think about this radiation therapy in the subject as a therapeutic or as a coronavirus infection, and then we can talk about how it can be useful for that challenge what we are talking about now. So this is a case in which using a standard pulmonary function test, the patient has nearly similar pulmonary function test after 4 months of radiation therapy. On the right, what I'm showing you is not the airway flow, the radiation dose for a cancer, what this patient got. So you see in milligrays where the patient got the more dose. So when you're giving the radiation therapy to this patient, this is the area where they got the most dose. So when we look into the ventilation scan of this subject, what we see is there is some difference, not much difference. On PFT, of course, you're not seeing at all. Although when we put so we are able to map literally where the dose was given, so where the therapy was given, the effect of therapy, to where the effect happened in the lung. That makes it very powerful when you're trying to develop, suppose, a drug right now for NCOV, right? So here, even the slight change in 3% with the heterogeneity index, we are able to capture it. But let me show you another case, which is a little bit more dramatic, where this subject has, even on a PFT, some change from 100 to 82, 84%. And you see this patient got a lot more radiation therapy. Most of this red is where you have a very, very severe dose of radiation. When we see this patient, pre and post treatment, the ventilation map, you see a significant change in the lung function. And let me show you the numbers. 13% for heterogeneity index, 5% changing for the VDP. And we can literally correlate with the dose. Where there is more dose, what is the effect of the therapy on the lung function or the ventilation? So that's it. Thank you very much, and I'm happy to take any questions. I believe you sent it to Frank online, and I hope you enjoyed it. Thank you. So what happened if we track, what happened in this? I see. So what the question we have here is that can we see a more severe form of mutation developing, and making things more worse than what we have right now. And I will walk you through what we know, now about how this all developed. So we know this mutation happened over time, maybe sitting in the wild animals, and then it propagated to the human from there. So I think as long as we are cutting those sources, there can be another forms of viruses or mutated forms sitting in, in dormant stage or infected stage in those sources. So epidemiologically, one thing what you can do is actually cut the source. So we don't see a reason why these mutations will be happening, but in normal process it does happen, and I'm sure like this spread, there are other forms of mutation that exist. So there's always a possibility, but I don't think that all of a sudden we'll start having a lot more, other forms of virusing, coming out. Very unlikely, yeah. Unless and until you're exposing subjects to some radiation or the things which lead to that kind of a mutation. I doubt people are either getting treated for the infection or getting over it, or they're not surviving it. So as long as the virus don't propagate more, I think we are in pretty good shape. Any other questions from the group over here? Yeah. Yeah.
One is for the detection. Let me try translate.
Yeah.
The currently is RT-PCR, as you mentioned, RT-PCR is used for the detection. There's some cases of false positive tested for as negative, but some the patients start to develop.
Yeah.
How do you think of the diagnosis?
Yes. Yeah. So right now we know the complete sequence actually for the coronavirus, and it's available through the Pasteur Institute website. So it is possible for you to actually even sequence the whole thing. Sequencing is not that cumbersome anymore, and we are talking about a viral genome sequencing. I believe the sequences what you see on the CDC website for the primers for the RT-PCR are probably most up to date, and so I would strongly recommend following their protocol. And if somebody is getting still false positives from that sequences, I will suggest doing the sequencing in that case. Although we technically know now from, I think that paper which I cited is in Lancet, that we technically know where the mutations are. So you can design your primers around the mutation. So you should be able to catch it. So it may be coming from a few weeks back when we didn't have all this information.
There is one case like cured by remdesivir from
yeah. Yeah.
But in China, there are over 300 cured. How is that more important?
Sure, Miss. If I don't know from where you have that news, I will be quite excited to get the source of that data, but I need to vet into where the data is coming from. So just for others who can't, can they hear you, or those who can't hear Frank? The question is about somebody identified 300 subjects getting benefit from this drug from Gilead, which I was talking about. Of course, there are not enough patients in the US, so we can only tell you about one subject, which they were just treating it, off the shelf use for this drug, and they saw some improvement. So, and it got published right away or shared, the information got shared, so that's how we know it. So if this is informal information, I would like these folks to actually publish it so that people can vet into the data. And it's certainly a good news. They're already.
I think that number comes from the CDC and the China. So they have self-recovery.
So I don't know whether it's the same drug or is the standard antiviral. Okay, so it's the Gilead drug. Okay. Yeah, I will. Yeah. All right.
Another one is from I think from physician. So he's asking. I also is asking about medical medicine. That sounds like antiviral.
Yeah.
So for antiviral treatment for HIV and HPV, you have to patient has to be rely on that medicine for like a lifetime. So how about this medicine? So they, I think they're asking about whether they can after the treatment, after the cure. So do they have to leave off this medicine?
Yeah, so it's the question is related to the autoimmune diseases like HIV or even some forms of HPVs that patient need to depend on those drugs lifelong. It's a good question, but let's look into the medicine aspect of it. If you don't have any type of autoimmune defect, you are not a susceptible subject that you'll keep on having repeated infection. So in that case, you don't need to be lifelong on the drug. In case of HIV, the subject becomes autoimmune and they lose their immunity, and that's why they need to be lifelong on those drugs, which is different for this virus. You can wean off certainly the patient, other than if they have other conditions or comorbidities because of which their immunity is weak, then of course they may need a long-term treatment. I don't think this is needed lifelong. And by the way, just to clarify, I have no association with Gilead or no commercial relationship whatsoever. Sure. Yeah.
So how do you think of this prospect? Are is a drug proposing for inspection could be the major go-to for other?
It is. It's called the alternative use of medicine. I think NIH now even has an institute doing that. So you can take compound libraries of existing drugs and screen on your condition and see if it works. Especially when you have some muscle-related disorder, or suppose I will use an example of field what I work on. I worked over the years with cystic fibrosis on various proteostatic proteasomal drugs. Several years back for multiple myeloma, they came up with Velcade or Bortezomib as a drug. It was not super effective. It still works on the blood cancers very well, but not on solid tumors. And there are reasons for that because other pathways get triggered. But we repurpose that to see if we can rescue the misfolded protein in another misfolded protein disease, which is cystic fibrosis. A lot of people have looked into all sorts of other things. So we know a lot about the mechanisms and pathogenesis of diseases right now. So you don't need to actually do like a fishing expedition. You actually can really use the knowledge and database. Somewhere, Frank, you can be really useful. That's where we have folks at Hopkins, or they used to be at Hopkins, where they develop Akhilesh Pandey's group, the human protein resource database. We have the complete genome protein sequences. I'm telling you, we have the viral structures and sequences as well. So you don't need to be totally hypothetical. You come up with the mechanism, and I'm telling you the pathology as well, the pneumonia and everything. So you can really identify the target. I'm sure that's how they come up with this Ebola drug to be tested or right away used for the patient, because doctors are allowed to use off shelf the drug for other purposes as long as it's FDA approved for other condition. But if it is not FDA approved for other condition, then you can't use it at all. There's always a risk associated with that. But certainly for the trials, preclinical development, I will say more than fishing expedition, I will vouch for, we really have means and tools right now to look into the mechanisms, look into that was my whole idea of showing you what information we have. We have protein structure, we know the pathology of the disease. So we know all the targets. We can screen against the drug libraries already out there, or the drugs which are already in use. Good idea. That's the way we go to the fast track drug approvals as well. Yep. Please. No, go ahead. Yes. Yeah. So in the drug development side, or even in the medical device side, you start with different phases. These are different steps: phase 1, phase 2, phase 3. In US, it's different from a little bit in other countries. Every country has different regulations. It's very tightly regulated. I'm sure Chinese Health Agency regulates in China. There are other places regulate in other countries. Here in US, we follow the FDA guidelines. So most of the preclinical testing for any drug is done, which we call as pilot and feasibility testing, is done mainly in a phase 1 trial. Then from there you move into phase 2, do some safety and efficacy study in the patient. In this case, if this drug was already tested on for the Ebola viruses, so it was already given to human. So there was safety and efficacy sort of phase 2 done already. So we have the safety profile of the drug. So now they are going for the effectiveness, which is a phase 3, right? And phase 4 is a lot more robust. So there are numbers of patients you need to do in each phases. You can read more online about that. So that's how you develop drug, and that's why it takes, billions of dollars to develop the drug. And unfortunately, 95% of the drugs get kicked out during the trial phases by the phase 4, which is good and bad. You don't want to give it to the subject, but there's a huge cost which goes behind. And when by the time the drug comes out in the market from the phase 4, like we recently had for cystic fibrosis, the corrector and potentiator drugs coming from Vertex, and the cost of those drugs, these patients have genetic mutations, so they're lifelong on the drugs. So $250,000, $500,000 per year. So you can only imagine what is the cost. So I hear that cry, but also see what goes behind for the companies to develop this. Yes.
In China, it goes directly to phase 3 without the Chinese data.
Yeah, and what they are, that's what may be the case also, because here, even if it has gone through phase 1 and 2 for other conditions, it is to still go phase 1 and 2 again in US for the new virus, the novel virus. So you can't take it like that. But in China, as Frank is telling, you can directly take to phase 3, which I didn't knew that. So and Chinese government or Chinese health agency is actually trying to get a patent on this. So they have to take over this drug to get a patent in China. And they're working on it, and seems like companies supportive about that because it opens the market for them. So hopefully if they have a successful trial, it will be fast track to the patients. And in this case, you need it anyhow, fast track. Yeah. Yeah. Yes. Yeah. And all these things, even the numbers I'm telling you, how they changed in 2 days since even, I was putting together the slide. So, it's just changing, and I'm keeping my fingers crossed. It don't spread too much. All right.
So thank you so much for this wonderful sharing.
Absolutely. Enjoyed.
So that will be the end of today's seminar. Thank you so much for attending online and on site.